Spinal cord is a section of nerve tissue that extends from the lower part of the brain to the lower back and communicates messages from the brain to the rest of the body. The main parts are the cervical section with 7 bones, thoracic with 12 bones, lumbar section with 5, and sacral with 5, and 2 coccygeal bones. The spinal cord is covered with protective layers: dura mater, arachnoid mater, subarachnoid layer containing cerebral spinal fluid, and pia mater. Looking inside the spinal cord, there is white and grey matter, posterior and anterior root, and the spinal nerve. There are 31 spinal nerves that send information to all different parts of the body. Each nerve goes to a specific area or part of the body. According to Johns Hopkins Medicine, an acute spinal cord injury is due to a traumatic injury that bruises, partially tears, or completely tears the spinal cord. According to Nori et al. 2017, the incidence of spinal cord injuries is 39 per million in North America, 16 per million in Australia, 15 per million in Western Europe. According to Johns Hopkins, the average age of injury is 42 years, but there is a trend of these injuries occurring in falls from elderly patients and generally an increase globally. SCI can occur from a range of things where the spinal neck is bent. This includes falls, motor vehicle accidents, sports and diving accidents, and gunshot and stab wounds. There are a few concepts that are necessary to understand when talking about acute spinal cord injury. 2 major parts of recovery from the spinal cord. Primary phase, the physical force and initial trauma. Secondary phase, delayed or progressive damage which continues after the primary injury and is most important when assessing neurologic deficits. This may include inflammation, ischemia, and axonal degradation, and may be preventable or reversible. Additionally, injuries can be classified as either complete, meaning there is no movement or feeling below the injury, or incomplete, where there is still some degree of movement or sensation. The current supported protocol includes the following things: to understand the full extent of the injury, an MRI, CT, full body examination, and a neurological exam is performed. If the patient is unconscious, if there are suspected not obvious injuries such as abdominal injuries, and to understand the full extent of the injury. American Spinal Injury Association Impaired Scale, AIS, is used to determine the level of severity of the injury. Blood pressure should quickly be maintained between 85 and 90 milligrams of mercury using vasopressors, and should be kept at this level for 7 days post-injury. If injury is high, such as C1 to C5, ventilation may be used if the patient is unable to breathe unassisted. Prophylactic anticoagulants should be given within 24 hours to prevent pulmonary embolisms. The patient should be catheterized to monitor bladder and kidney function. If possibility of paralysis of intercostal muscles, chest physiotherapy should be performed if patient is stable. Decompression surgery may be performed to release pressure around the spinal cord and stabilize the area. The use of corticosteroids is highly controversial. However, recent literature has advised against it. Rehabilitation should begin once the patient is stable and preventing secondary complications becomes their priority. Rehabilitation is used to improve the patient's ability to perform daily tasks such as eating and bathing, help the patient accept the new lifestyle, and finally is used to aid integration into society. Methylprednisolone is a glucocorticoid and has strong anti-inflammatory effects that has potential to decrease the severity of secondary injury. An NAS-CIS trial demonstrated it was highly effective, better outcomes compared to placebo if used in high dose within 8 hours of injury. However, according to Roger et al. 2016, the study had major statistical and method errors and didn't adjust for baseline severity of injury. Evanil et al. 2015 adjusted for differences but found no benefit, and Roger et al. Suggests there is a significant risk of complications with high-dose steroids. Despite this, 90% of American spine surgeons still use methylprednisolone within 8 hours. Minocycline is an antibiotic with the ability to cross the blood-brain barrier and has potent anti-inflammatory properties. Animal studies have shown to protect neuron loss, and Phase 2 human trials have shown improvement of 14 grades on the ASIA score with incomplete cervical injuries. Anti-NOGO-A antibody is a monoclonal antibody. Major inhibitory fractions within central nervous system myelin, iron-1, which promote axonal sprouting and functional recovery in animal models. Mild hypothermia is a process of reducing the core temperature via ice pack, cooling blanket, and intravascular catheter cooling. This reduces basal metabolic rate and systemic inflammatory response. Studies have shown better neurological outcomes, sparing of local tissues, and improvements in behavioral recovery long term. Decompression surgery less than 24 hours after injury has been shown to improve outcomes. On the AIS scale, 56% of patients with early surgery saw improved outcomes of at least 1 grade, compared with 49.5% in the late group. Also, an improvement of 2 or more grades occurred in 19.8% of early group versus only 8.8% in the late group. CNS axons do not regenerate due to a dense scar made from regeneration inhibiting proteins on the cells. Schwann cells are known to stimulate growth in the PNS. Studies transplanting cells to CNS in rats have been shown to reduce lesion size, remyelinate axons, and increase motor recovery. Neuroprecursor cells are multipotent CNS cells and able to differentiate to neurons, astrocytes, and oligodendrites to replace lost cells and provide local trophic support. Commonly found in central canal of spinal cord and mobilized after injury, however, in only small amounts. Animal models with cervical and thoracic SCI have shown reduced cystic cavitation, remyelination of axons, and improved behavioral outcomes.